Welcome, everybody. My name is Nelson Lee, the Director of Institute of Health Emergencies and Pandemics from IFP Institute for Pandemics. Thank you for joining us in our Catalyst Seminar Series. Regarding our Catalyst Seminar Series, it's since 2023, our institute has provided over $1 million to support research teams at the University of Toronto to support collaborative interdisciplinary research projects that tackle challenges in pandemic preparedness, response, and recovery. And the purpose of this seminar series is to highlight the interdisciplinary teams and their work, and to allow them to share the research findings with the wider group. And I'm also hoping that we can build new connections and collaboration between teams and our attendees. So there will be two presentations today. The first one by Dr. Andrew Pinto, the second by Dr. Shaun Morris, who I'm going to introduce in a minute. And before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. So now I'm going to turn over to Eva. We're going to talk about a few housekeeping items. Eva.
Hi there. So if you need to use closed captions, there is a captions button at the bottom of the screen that you can click to turn off or on. They are AI generated, so they may not be the best, but they are available. If you have any questions for the presenters, there is a Q&A feature at the bottom of the bar. Feel free to enter your questions at any time. We'll get to them at the end of both presentations. And finally, we will have this recording and the presentation slides available about a week after the webinar. We'll send that out to everybody who's registered, and the recording will go out through social media and our listserv. That's all from me. Thank you.
Thank you, Eva. So now I'm going to introduce Dr. Andrew Pinto. Dr. Pinto is the founder and director of the Upstream Lab, a research team focusing on tackling social determinants, population health management, and using data to enable proactive care. He holds the CIHR Applied Public Health Chair in Upstream Prevention. He is a public health and preventive medicine specialist and a family physician at St. Michael's, Toronto downtown, and an associate professor at the University of Toronto. He is also the Associate Director for Clinical Research at the U of T Practice-Based Research Network, Utopian, and the lead for Artificial Intelligence in a new initiative at the Department of Family and Community Medicine on how technologies will change healthcare. His presentation today is on the understanding the impact of COVID-19 on communities made vulnerable by social and economic conditions and the subsequent policy response in Canada. I will turn over to you, Andrew.
Thank you so much. And it's a real honor to be asked to present. And I just want to say a big thank you to the Institute for the funding for the Catalyst grant that we received to do this work. Let me just share my screen with some slides. I hope that shows up okay.
Yes, thank you.
Okay, thank you. So as was mentioned, one of my main roles is directing a team called the Upstream Lab. We're turning 10 years old this year, and it's a team that's grown over time. We're a home for a number of scientists, so not only myself, and we have a fantastic team of staff and graduate students. We work in a few key areas, including developing and evaluating interventions that address social determinants, artificial intelligence, and its implementation in primary care and public health. And we also conduct large trials. So at the start of the pandemic, Some of you will remember kind of those very early days of 2020, and just the enormous changes that were happening very quickly, shutting down travel, closing borders, a rapid shift to working from home. Um, and it obviously affected all of our lives. One of the kind of key things was that many communities that have been made vulnerable by social and economic policies over time recognized very early that they would be hit hard by this new pandemic. And indeed, previous pandemics had had a disproportionate impact on low-income individuals, on racialized individuals, on low-income workers and others in the past. So many of them started to call for kind of a need to protect their communities. And we conducted this rapid review of the studies that emerged in the very first 3 to 6 months of the pandemic. We quickly identified many, many studies that indeed showed that certain communities, low income and racialized individuals in particular, were experiencing higher rates of morbidity and mortality related to COVID, even in the very early days. One of the, key things in Canada is that we do not have a long history of collecting social data um, in healthcare spaces or in a lot of public health outside of very specific areas. So an interesting kind of anomaly almost is that if in Ontario, if you conduct a test for HIV, on the requisition itself, it actually asks about social demographics, including things like race. Um, and that came about because of a lot of advocacy noting that certain groups were being disproportionately impacted. Um, but it's actually one of the few diseases where that is actually part of the mandatory data that's collected by local public health units as they follow up on people who test positive. So the upstream lab in the preceding years before the pandemic, we had done a lot of work on social data collection, actually going back to 2011 or so. So we had done work where we asked people how they felt about being asked about things like their income, their race, their housing status in the context of a healthcare encounter. So in April of 2020, we put together a very brief white paper essentially and circulated it. We made the case that we think that during this, new pandemic, facing a new pathogen that is going to cause a lot of problems, we should collect data on race and other social factors. And that was one of our key recommendations. We also argued that we should be using the same questions across provinces. Um, Obviously, that's so that we can compare the results. Also, that there should be a preface that explains that it's not to do with race as a biological issue, but rather this is a social construct, but it does make a difference in terms of how we're treated by systems. And also, there should be a need to be transparent and work with communities around the use of the data. Um, Kai in May put out like an interim update, also, suggesting this and drawing on some of the work that we had done. And many of you will know that in Ontario, there was actually an initial reluctance, and then after there was some pressure, public health did actually move to collect this type of data. Um, it ended up becoming very important to being a foundation for community investment and community outreach programs and things like that. And these are just some examples. And what we saw is like almost as soon as the data started to be collected, there was really significant disparities that were noted. So this is from Toronto and the Toronto Public Health area. You can see Black, South Asian, Southeast Asian, Latin American groups are very overrepresented in who was getting infected with COVID. because of a lot of the community outreach, though, and work to actually address these inequities, there positive news was there was a shrinking in about a year's time. There was a reduction in these inequities. So this is a rare good news kind of example that we can not only identify inequities but also tackle them. Also, in the early years of the pandemic, my colleague Nav Prasad, and I was part of this work, led an effort to say, as we think about recovery from the pandemic, what should be some of the policies that are implemented? And these are, some of the things that came through this review and Delphi process. Recommendations around income, housing, addressing access to healthcare, but also things like systemic racism and intimate partner violence and access for children in particular. So that's really kind of the jumping off point for this Catalyst grant. So we received funding to really first begin by saying which jurisdictions actually implemented policies. So we took that paper and that set of recommendations, and there are 13, and they cover a wide range of items from cash transfers, expansion of supportive housing, food distribution, as well as care for people who are incarcerated. Some of you may remember that COVID was really very bad in prisons and jails and other kind of spaces where people were crowded together. Um, and so we did a look at each province and territory, and we used a variety of sources from the ministries of health to press releases that were issued to news coverage and a variety of sources to say what was actually implemented during the policies. Oh, sorry, during the pandemic. What we can see, this is kind of a grid that shows that actually there were quite a few policies implemented in a number of jurisdictions. There were some where there was kind of very few, jurisdictions implemented something, and also no province or territory did everything. But some of the gaps were in expanding HIV and hepatitis C screening, um, improving healthcare and correctional facilities, enhancing healthy food distribution, and taking efforts to address systemic racism. Also, kind of some other policies that were or were not implemented. One area of interest for me is around eviction prevention, and very few places seem to implement something that prevented people from losing their homes during the pandemic. Um, and you can see also, of course, very few jurisdictions tackle access to prescription medications. There's a lot of, hope that the federal government will implement pharmacare, but not as yet. We also did a series of scoping reviews with this grant and with other funding that we had. The first that's been published has been looking at the evidence around the impact on racialized populations. We identified almost 40 studies and reports that confirmed, what that initial rapid review had found. That was an international rapid review. This is focusing just on Canada. And not surprising, we found that racialized communities had high rates of morbidity and mortality, reported higher rates of discrimination and mental health concerns, and also challenges with accessing healthcare and also with food security as well, which I think is a really growing problem. But a crisis or a public health emergency really makes everything a lot worse. We also have two other scoping reviews. One that looked at people who could not shelter in their home. And we identified a number of papers that looked at this. People experiencing homelessness were particularly impacted by the pandemic. But also, many of you will know that people who are experiencing homelessness, actually quite a large number of them are actually also working at the same time. And they often were in jobs where they could not work from home. They were, not only were they not having a home, and experiencing homelessness, but also they also were, if they did have employment, they were working in jobs that were not virtual. They had to be in person, and these often exposed them to COVID. Um, Even just anecdotally, many of you probably had this experience of if you were fortunate to work in a job, often academic jobs during the pandemic were like this, where you were essentially working from home. You are not coming in contact with people with COVID, versus if you're working in a job like retail or kind of essential services of the city, you were being exposed to COVID. Um, the other paper, which has actually been accepted to a journal, looked at the impact of COVID on low income. Not as many studies that we found in this area in Canada, but again, confirmed kind of what you would expect: higher rates of morbidity and mortality from COVID, concerns about mental health concerns, and also key social factors like food security as well. The last thing that I'll mention is that this all of this work is really informing some ongoing work that we're doing. We're very fortunate to be leading a very large national initiative called Prepared, which is funded by the federal government, the Canadian Biomedical Research Fund, and is supported by our U of T-based hub called HIQ. Prepared has a number of objectives to improve patient care in primary care and emergency departments through improving access to rapid antigen testing for people presenting with respiratory illness. It also has a very strong focus on strengthening surveillance through collecting swabs as people present to emergency departments and primary care, but also building an at-home testing system. And we're just launching this now. So if people living in specific areas of provinces actually are eligible to connect with us and order a kit that's delivered to them. A third objective is connecting people to clinical trials, and both Nelson and myself are very interested in this area of studying treatments that are effective to treat people who have acute respiratory illness. And then finally, Prepared is about supporting biomanufacturing. So, as we're doing this work, we're keeping in mind the differential impact that the COVID-19 pandemic had. And really, this is informing particularly the surveillance aspect. Which communities are we working with to try to enhance surveillance ahead of a pandemic? So just to conclude, pandemics impact low income and racialized communities in a substantial way. And it's something that's very recognized by community leaders. Data is essential, but it must be combined with community data governance and communities having input on how to interpret the findings. How can we, it's not enough to just identify these inequities, what's actually can be done, whether it's like a community ambassador program or town hall meetings or specific communications as well. More can be done to be ready for future pandemics in terms of protective policies. What I think I would love to see is that each province and territory has an approved plan that if there is another pandemic, and there inevitably will be, that there's a package of policies that get enacted right away to protect vulnerable communities. And a lot of us are involved with pandemic preparedness projects. We can begin to really build relationships with communities, and of course, this takes time. And it's best to do this now ahead of a future emergency and take the time to build these relationships in a thoughtful and respectful way. So I'll end there, and if to follow kind of what we're doing at the Upstream Lab, we have a monthly newsletter as well. Thanks so much.
Well, thank you, Andrew. We will have the Q&A time after the second presentation.
Yeah.
Although there is a quick question typed in the Q&A asking whether you have collected information about occupation at the start of the pandemic. Would you like to respond to that quickly?
Yeah, I'll respond quickly to that and then turn it to Shaun. Great question. So I'll say it was really not so much us collecting the data as more local public health units and provincial public health across the country. I know that some jurisdictions did collect occupation, and then often they were very involved with occupational outbreaks that happened. Some may remember like the Cargill meat plant in Alberta. There was is I think Canada's largest COVID outbreak that happened there. So there was some work, but it's not in a systematic way. Separately, we've done some interesting work on how to collect occupation in kind of an easy to understand structured way, and also categorize it using occupational health categories. And I'll try to see if I can put the link to that in the chat. It is tough to implement, but we've done some kind of preliminary work on trying to do that.
Well, thank you, Andrew. So let me introduce second speaker, Dr. Shaun Morris. Dr. Morris is a clinician scientist in the Division of Infectious Diseases, a scientist in Child Health Evaluation Sciences, and the co-director of the Center for Global Child Health at Hospital for Sick Kids. He's an associate professor of pediatrics and is cross-appointed to the Division of Clinical Public Health at the Delaware School of Public Health. His presentation title is Leveraging Data Science to Improve Vaccine Equity and Pandemic Preparedness Among Children who are newcomers to Canada. I'll turn over to you, Shaun.
Thank you, Nelson. Can you hear me and see my slide in the correct presentation mode?
Yes.
Great. Okay. Thank you very much for the introduction. And to echo Andrew, thank you very much to the Institute for supporting our group's research and catalyzing what I think is for me, it's a very exciting project, and I think it has a long runway for work over the next few years. So I suspect that I don't really need to convey to this group that immunization is really the linchpin or an essential part of health across the lifespan. So this talk will be focusing on children, and I'm a pediatrician, but I do want to note that immunization is important right across the lifespan, routine immunization as well as pandemic-related immunization. And this is because there are benefits to individuals. So the individual benefits by having a reduced risk of acquiring infectious diseases, as well as a reduced risk for severe outcomes from infectious diseases. And of course, there are also benefits to populations, and these benefits include, but aren't restricted to, reduced transmission of vaccine-preventable diseases within the population, and the subsequent reduced draw on healthcare resources, and as well as improved pandemic preparedness, depending on what vaccines we're talking about. And as I think we all know, the immunization systems in Ontario and in Canada and really in the world were not optimal before the pandemic. And then during the pandemic, there were multiple types of disruptions to these systems, and many of the ramifications of these continue into the aftermath of the pandemic. One point illustrating this is the recent measles outbreak, largely in children, but also in adults in Ontario, which resulted from imported cases. So people from other countries who flew to Canada and encountered other individuals within the population who were or under immunized for measles. And then local transmission within our own setting occurred. And part of the reason why our systems are not as strong as they could be are because immunization systems are fragmented and not fully digitized. And so I'll talk a little bit about that here. So I want to spend the next couple of minutes talking about the current immunization context in Ontario. So I think it's important to first of all highlight that there are different practitioners in Ontario that can administer vaccines. And these include physicians, and amongst physicians, it could be family physicians, it could be pediatricians, it could be obstetricians, it could be internists, nurses in certain contexts, public health professionals, and pharmacists can also administer vaccines. So many different professions administer vaccines, and this happens in different settings, including clinics, and they could be primary care clinics, they could be vaccine clinics, they could be subspecialty clinics, schools. So there are vaccines that are given across Ontario in grade 7. in schools. Pharmacies can give certain vaccines to certain people. And in certain cases, vaccines are also given in higher level care hospitals. So that's a bit about who's giving vaccines and where. And you can already see that it's complex. Further adding to the complexity is the fact that every province in Ontario maintains its own system for immunization records, and there's not a lot of crosstalk between these records and these systems, and there's no national registry for immunization, which I think many of us recognize there needs to be. In Ontario, there's two main electronic systems to know about. One is called ICON, and in this system, families and individuals can proactively report their own vaccine history into the ICON system, which keeps a record of it. However, a fundamental problem with this system is it's not independently accessible by healthcare providers to understand someone's vaccine history. The other key system is called Panorama, and this is used by public health to manage immunizations, track inventory and records. But again, it's not accessible to frontline healthcare providers. It is accessible to public health. Many of you will be familiar with the Ontario Yellow Card, which for many of us is still our main vaccine record. It's a physical piece of paper that we sort of show to doctors and nurses and public health to indicate what vaccine we received and when. And pertinent to this conversation is some public health units, but not all, offer translation services for vaccines that may have been received in another country. This is inconsistent, and that's the fundamental problem that we're going to talk about today. And I do want to note that school registration is one of the main times in life that immunization records are required to be shown. And so students in Ontario can be prevented from registering or suspended from school if records are incomplete or it is documented that they have not received certain vaccines. So how this project emerged, so similar to Andrew's presentation, my group had a lot of work happening through the pandemic, and some of that work was research and some of it was clinical. And clinically, we started a service at SickKids called the Vaccine Consult Service. It was a phone-in line, basically, to provide information to the public about COVID-19 vaccines. After the pandemic, it transitioned into what we call the SickKids Immunization Info Line. And so this is what we have now. And it's a nurse-led line that basically offers access to the public to call us and access expertise to answer any question related to immunization in children or in pregnancy. It's free. It doesn't require any referrals or consults. And so we're really trying to democratize access to really high-quality immunization information. One of the issues that we repeatedly heard about through the immunization info line is that the documentation of vaccines is a major issue, especially for newcomer families. And what I mean is that when people come to Canada, their vaccine records are generally on paper, and they're often in a different language. And the translation of these records and sort of incorporation of these records into our system, especially given the fragmented nature that I described, is very, very challenging. And this is important because newcomers are an important population. So obviously, health equity dictates that all children should have equal access to vaccines and health. But I think as Andrew illustrated in his talk, there are many circumstances where this is not the case. And this is another one. So newcomers to Canada are defined as people who have come within the last 5 years from another country and make Canada their home. And it's an important group because it's a big group. So according to the 2021 census, immigrants make up about 20% of the Canadian population, and about 20% of the immigrant population are children. And Toronto obviously is not the same as Canada, and Toronto is even more represented in terms of the immigrant population than newcomers. So the most commonly quoted statistic is that about half of all people who live in Toronto were born in other countries, and the figure on the right just shows the language distribution, the primary language spoken at home across the city. And you can see just from the diversity of colors, without paying attention to the specific languages, that there are a lot. So when a person comes from another country, typically what they do is they present to some sort of healthcare worker, and they present their paper record of vaccines received in another country. And it's the job of that healthcare provider to confirm what vaccines have already been given and to try to understand what catch-up may be needed. And what catch-up means is basically providing additional vaccines to get this individual vaccinated as per the Ontario schedule for that individual's age. In addition to that, the job of that healthcare provider is also to understand the risk profile of that specific patient and to understand if they may need any additional vaccines on top of the routine vaccines. However, the fundamental challenge is that these vaccine records that are on paper and coming from other countries are very often in other languages. They may be in different scripts. They're almost always in a different format. And the countries from which people are coming may, in fact, just have different vaccine schedules. So different vaccines are available, sometimes more, sometimes less than Canada, given at different times of life. And translation of this is complicated, and understanding it is complicated and very time consuming. And it is very often too much time and too much complexity to deal with in a quick clinical visit. The picture on the right is an example of an actual vaccine record from Pakistan. And I hope that this just sort of illustrates how challenging this is. This is a different schedule in a different language and in a different script. And if you have just a couple of minutes to try to understand someone's vaccine status, unless you speak Urdu and read Urdu, in the case of this particular record, it's impossible. So I've clinically had to deal with this situation before, and it can be done, but it requires significant amounts of time, cross-referencing different resources, and a lot of troubleshooting to sort of map this to the Ontario schedule. So the result of this is that newcomer families may face very systemic and important barriers in having their immunization status understood, and thus barriers in having their immunization status, quote, caught up to the Ontario schedule. And I've listed some of the barriers that they face when trying to tackle this problem of understanding international immunization records. And so how can this affect the family? Well, it can introduce financial and emotional burdens and stressors. So a child may be unable to enter school. As we said, in Ontario, there are rules around documentation of vaccines before entering school. It may mean that a caregiver is unable to work, that's unable to earn an income. There are the delays in the benefits to the individual and population that I mentioned in my first slide about vaccinations. And it's a fundamental problem that I think we've got a better understanding now, needs new solutions to deal with. And in regard to pandemic preparedness and readiness, it's also very important not just to understand people's routine immunization status, but also in a future pandemic, a fundamental part of response is to understand who is immune and who is not immune. And so all of the learnings that we'll be talking about in today's lecture and parts of the project apply equally to routine immunization, as well as potentially in the future vaccines related to a potential future pandemic. So what I've tried to do in the first 10 minutes is to sort of define the problem and how we came to think about it and approach it. And in terms of solutions, we thought that we needed to think outside of the box. And so the typical people who are thinking about immunizations are clinical providers, so physicians and other healthcare providers. So in my world, infectious diseases and pediatrics, public health, but who's often not at the table is data science. And around the time of the application to this Catalyst grant, I was reading an article about something completely different, and it was about the use of data science techniques to try to understand ancient languages that were sometimes found on pottery or on scripts, but hadn't been translated, hadn't been understood. And just about all the incredible scientific progress that had been made in using AI and data science to understand and translate languages. And it got me thinking about maybe there's an application for a similar technology in my world. And so I started reaching out to some people and asking some questions and doing some reading. And eventually what we did is we put together a group of people who want to try to look at this problem from a new perspective. And we assembled our core project team. So I partnered with Dr. Mariano Consens, who is a data scientist at the University of Toronto. He's in the Faculty of Mechanical Engineering. So a completely different scientific world than that I come from. and then a group of co-investigators from sick kids, so pediatricians and infectious disease doctors, key leaders from Public Health Ontario who work in the immunization sphere, as well as Christina, who is another data scientist at the University of Toronto. And we had two main project goals that were part of this Catalyst grant. So number one is we wanted to understand and document the current processes that happen when a newcomer family comes to Canada and how they interact with our healthcare system to translate and understand their international vaccine records. And then we wanted to begin to explore how data science could potentially be used to improve the efficiency and equity of these existing processes. So the first major project activity is interviews with newcomer families. And all of the work that I'm describing today is still ongoing. It's a work in progress. So we have partnered with the Toronto District School Board, and with their assistance, we've identified a handful of schools throughout the city that are in areas that have disproportionately high newcomer populations who are within the population and also within the student population. And then we've had project team members who have gone to the schools, who've explained the problem that we're interested in tackling. And we've been recruiting families, newcomer families, to participate in qualitative focus groups and a series of interviews so that we can gather reflections on these issues from the lived experiences of these families. And what we are trying to do is we're trying to get sort of a range of families from different countries who have all come fairly recently with children of different ages who had either positive or negative or challenging experiences in interacting with our system around this issue of vaccine, international vaccine record translation and assessment. So these interviews are ongoing. In parallel to this, we have multiple lines of investigation about the public health side of things in Ontario. So we've had a series of meetings with Public Health Ontario stakeholders, so the public health at the provincial level. And with their collaboration, we have set up a large stakeholder meeting that's happening in about 2.5 weeks with representatives from all 34 Ontario public health units. So these are the public health districts around the entire province. Specifically to try to understand what supports they offer, what supports they don't offer, what are their gaps, what are their internal processes, and what sort of solutions, particularly technical solutions, would they be interested in having to help them to streamline their workflow in relation to assessing international vaccine records. Following the provincial public health stakeholder meetings, we have planned a national public health meeting where we're going to replicate a lot of what we have done at the provincial level to try to understand how similar or how different these issues are across the country. We also hope to expand it beyond public health to include other stakeholders, including on the physician side, the nursing side, and the researcher side, all with the longer term goal of trying to understand what sort of technical solution would be very helpful. So the technical solution is going to come from the data science part of our project. So as I said already, we've built new collaborations between sick kids and data science researchers at the University of Toronto. And in parallel to this, we've initiated a new research collaboration with Aga Khan University in Pakistan, specifically to access over 100,000 actual vaccine records, scanned images of actual vaccine records from children in Pakistan from the entire country. And these are records that are in different languages, in different formats, and different scripts. The picture that I showed at the beginning was one of these records. And our plan is to use Pakistan as a case study, proof of principle, to see if a technical solution can be developed. So what kind of technical solution are we hoping to develop? So essentially, our long-term goal is to have an AI-based tool where one could take a photograph of a vaccine record. So imagine using a smartphone and taking a picture. And no matter what the format of that international vaccine record, no matter if it's typed, if it's printed, if the writing's bad, if it's smudged, if it's in English, if it's not in English, if it's in a totally different script, to have the ability to use the AI to understand what vaccine somebody has received and when, to map that to the Ontario schedule, and then to ideally generate a catch-up plan so that child or adult as it may be able to become fully immunized as quickly as possible. So dramatically compressing the time and the money it takes to get through that stage of understanding what vaccines somebody has had. And so the strategy here is we're starting by examining different currently existing pipelines that can assess photographs of scripts. And we are going to compare these to each other as well as to the gold standard of manual human translation by native language speakers. And this has already been done for the records from Pakistan. And then we're going to use those records from Pakistan as a test data set and then a validation data set to understand which of these tools performs the best and then work on refining it. So I think I've mentioned this before, but one thing I haven't mentioned before is that one of the things that has come up in our public health meetings is the importance of whatever tool is developed, that we are thinking now about how the results will link to existing vaccine databases, and in the future, if there is a more all-encompassing registry, how the digitized results of our tool could be linked and uploaded basically into these registries. So the progress, I've sort of touched on a few things to date. It's been very complicated because of the relationships between SickKids and University of Toronto and Pakistan and different data sharing agreements. So those are all done now. All of our ethics are in place. We've got the focus groups ongoing. We've got the public health stakeholder meetings ongoing. We've recently secured access to the high-powered computer cluster at SickKids. We've got the vaccine records from Pakistan that have essentially just arrived, and we're looking forward to continuing this work. And hot off the press, to continue this work, just yesterday we found out that we received a $100,000 grant from the Data Science Institute at University of Toronto to continue this work. So the work to date has been funded by a Catalyst grant, and the way I think of Catalyst grants is they're intended to catalyze new relationships, which this one has, new ideas, which this one has, and new projects that can generate initial pilot data, which can be used to apply for larger funding, which this one has as well. So I will wrap up there and happy to take any questions. Thank you.
Thank you, Shaun, for the presentation and also sharing with us some ongoing works. That's fantastic. I can see that in the Q&A section, there are a couple of questions, which I believe that both of our presenters can access. I won't be able to read out every word in those questions, but I believe that the first question is about equity relevant disaggregated data collection. And for this question, I believe that Andrew can address that. And the second question is about the vaccination program in schools and whether there will be any enforcement. And I'll assign this question to Shaun, if I may.
Yeah, thank you for the question. So I've been involved with this work around disaggregated social data collection or equity data collection for quite a while. It's been it's been a complex journey over a number of years. I would say a few kind of key, I guess, thoughts are across Canada, thankfully, over the last decade, there's been a huge kind of awareness around the social determinants of health and the need for this type of information. I think every jurisdiction struggles with really the best way to collect this type of information. There's really interesting thoughts about using things like health card renewal or linking data sets between, different sources of information, to collecting it from people individually. in Ontario, actually, Ontario Health has an equity kind of and diversity group within it that really has helped lead the way. And they have been working with different parts of the health system to see this kind of get operationalized. They have primarily focused on hospitals, which often have the resources to collect this type of social data. And we see some really good examples of its use, actually. I want to really highlight the Center for Addiction and Mental Health here in Toronto as I think a real leader in collecting and actually publishing this data and using it. But many other kind of hospitals are as well. For example, the Hospital for Sick Kids and UHN and Unity Health Toronto and others. The other big area has been in community health centers, which for many, many decades have collected this type of data and have used it. So it's coming along, but it's I think where we're at right now is we need to move from kind of the very traditional, typical Canadian pilot approach to a more unified system, where it's not only kind of collected in a standard way, but it's also there are community data governance processes set up at a provincial level so that not every institution has to do that. It's interesting because there's maybe a kind of a coincidental parallel with Shaun's presentation on vaccine data and how fragmented it is. And maybe we, need to take a step back and look at just overall our approach to health data in this country and really engage the public more in that. A lot of it's often driven by researchers. And then people who work in healthcare and public health systems. But I'd love to see us engaging the public more in this discussion. We actually have a slow moving kind of initiative called Our Health Data to engage the Canadian public in really kind of that high level thinking.
Thanks, Andrew. Shaun?
Yeah, so the question was about are children actually prevented from going to school if they can't document that they've received certain vaccines? And I think the answer is sometimes. So one of the things that we found in our surveys of the different public health units is really that it's really inconsistent how things are done across the province. And sometimes the quote unquote letter of the law is very strictly interpreted and applied, and other times it's not. There are ways in which a child who is not immunized can get exemptions. So there's something called a medical exemption, which has to be signed by a doctor or a nurse practitioner on a provincial form that basically states that a certain vaccine cannot be given for a valid medical reason. An example of that would be the measles vaccine is a live viral vaccine. So somebody who has a significant immune compromising condition may not be able to receive that vaccine. And then there are non-medical exemptions, which require different forms and a certificate and a notarized statement of religious belief or conscious objection. And if these pathways are followed, then children can attend school. But these are complicated and not everybody has access to these pathways or awareness that they exist. The majority of the time, and we know this from other work that we've done, where a child does not have a vaccine that is required to attend school, it's not because they're choosing not to have the vaccine. It's often a situation where either they have received the vaccine and it just wasn't properly documented, or they would like to receive the vaccine and they've just come to Canada, but there are barriers to them accessing a vaccinator. And so these would be examples where the problem can be solved if the child can be vaccinated and the family is willing to do so. We just need as a system to do a better job of vaccinating those who want to be vaccinated, I think. So the answer to the question is it depends and sometimes.
Shaun, there's actually another question in the Q&A section specifically directed to you. It's about the lack of vaccine data registry and any thoughts creating a unified health system and online record system. What do you think?
Yeah, I mean, I think this sort of is exactly what Andrew was just suggesting is that so yes, I mean, I think for immunization, we need systems where it is very easy for everybody who exists in the ecosystem where they might need that information to access that information. And that is everybody from the families through to the public health system, through to the medical system, through to the school systems, et cetera. But I think we would probably be short-sighted if we if our ultimate goal is to build just that, because I mean, as Andrew said, what would make a lot more sense is if data in general that is about people's health and useful for people's health, it needs to be integrated and it needs to be accessible. Um, so yeah, I mean, I think that that's the long-term goal.
Well, one question from myself. You're using AI to read those vaccination records issued from elsewhere. Any success so far?
Yeah. So we haven't started doing that part yet. And the reason is there were a lot of challenges in getting access to the international vaccine records, which literally has just happened in the last week and a half or so, in terms of identifying an adequate number, in terms of, getting everything scanned and translated by human experts, and importantly, getting all of the data sharing agreements and sort of legal documents in place. So that will start imminently. But what I will say, Nelson, I mean, I think that there are lots of examples now from other areas, and I sort of alluded to what stimulated this whole idea in my case, where AI was being used to understand ancient languages that had never been translated before, ever. Um, so it has shown lots of promise and success in some of those realms. So I think we're all confident that technically this is possible. I think that the bigger challenge is actually going to be that to train AI to do this, you need access to large amounts of data. And so in the unique case of Pakistan, I think we have that. And that's because I've worked in Pakistan for 15 years and have some very good pre-existing connections there. But, for this to be a truly useful tool, it would have to work well for basically any record from any country. And that would eventually mean access to data to train on from actual real records from all of those countries in all languages. So that I think is going to be a very big challenge. I think as part of our next stage, what we have proposed is trying to identify and access additional records from other countries. Yeah, but I'm confident that technically it can be done. I think the challenge is going to be in the training of it.
Thank you, Shaun. I think that we have got time for one last question, and I believe that this is for Andrew. How do we engage the public? Any involvement of patient partners in your project?
Yeah, absolutely. I mean, this is a great question, and um, there's a few. We absolutely have many patient partners in many of our projects, and actually on our website we also feature kind of members of our overarching Upstream Lab council, which include people from across Canada. But we also have people specific to different projects like Prepared or a trial we did, Cantry COVID, and so on. I think they're essential, to this work because they really bring their own perspective to this type of work, and help inform and help shape it. Ideas like our health data and building a movement to engage the public emerge from conversations with patient and community member partners. It's interesting because Shaun and I and many people probably listening struggle with these issues, and we spend so much of our time trying to address them. And when you speak to members of the public, they're just shocked, that we don't have all the data, that my pediatrician or my family physician doesn't have access to this. And to them, it absolutely makes sense that they should, and it should happen. Um, for those who are interested, there's likely going to be new legislation coming through at the federal level that will really govern a lot of health data. And I'd really encourage you to be part of the conversation and helping shape it. Really not primarily for research, but for actually just improving the care that everybody receives in the health system. But then secondarily, it will make research and public health, epidemiology, and other type of work a lot easier too. So it's something called the connecting care kind of legislation that'll likely be brought back, and hopefully it's a good opportunity to try to improve some of these areas as well.
Thank you, Andrew. Well, I would like to congratulate both of you in your successful projects. Thank you so much for taking your time and sharing your findings and your work. I can feel that there's a lot of enthusiasm among our attendees, and I'm sure that very likely you will receive a few follow-up emails afterwards. So thank you so much. Before we end, I will turn over to Eva to tell us a little bit more about our Catalyst Grant seminar.
Great, thank you. So this is an ongoing series, and the next session will be on February 10th. The topic will be on women and children, so looking at the pandemic's impact on children and youth's mental health, as well as gender-based violence. We will hear from Kuan Liu, Beverly Esu, and they're both from the Dalla Lana School of Public Health, and also Sarah Kaplan from Rotman School of Management. So please feel free to use the QR code to scan and register, or you're welcome to go to our website, which is pandemics.utoronto.ca, to register for that event or for any other events. That's all from us. Thank you so much to everyone for attending. Thank you for the presenters for such an insightful, for both very insightful presentations. We will get the recording out to you in about a week or so, and look forward to seeing you in our February session. Thank you so much.